stopwatch. 1. Hello, good morning everybody. Welcome to our Facebook Live event. My name's Peter Anderson and I've got the privilege of hosting this session on behalf of the Centre for Research Excellence in Newborn Medicine, as well as our partners, Life Little Treasures Foundation. This is our second Facebook Live event in the Prematurity Roadmap series, and today we're going to be focusing on autism spectrum disorder, which from this point forward we'll be referring to as autism. And we're going to be particularly focusing on autism in children born preterm. Now, today this event is going to be largely a question and answer session, but we're going to start with talking to our panel of experts, but we're also going to be having a few short presentations just to give you a bit of background information on autism and prematurity. So for this, for today to work, we really strongly encourage you to post your questions, and you can do that by typing it in the comment section on the Facebook page. We'll try and answer as many questions as we can during the course of this session, but based on experience, there's a chance that we may not get through all your questions, in which case we'll try and address your questions by typing them in on the Facebook page after this session. So, I'm going to start by introducing our panel. I've already introduced myself, Peter Anderson. I'm a psychologist. I'm Professor of Paediatric Neuropsychology at the Monash Institute of Cognitive and Clinical Neurosciences at Monash University, and also Group Leader of the Victorian Infant Brain Studies Group here at Murdoch Children's Research Institute. My research focuses on children who've had an injury to the brain early in life, usually around the time of birth, and I focus on those children because we know those children are at high risk of having developmental problems as they grow older, including autism. And my research tries to find why some children end up developing conditions like autism and others don't. And if we have that information, hopefully that information will help with the development of interventions and help us identify which children are at risk of problems so that we can put those children into close surveillance programs. Next to me is Professor Katrina Williams. Katrina, if you can start by telling the audience a little bit about yourself, your professional background and the work you do.
Thanks very much. I'm Professor Katrina Williams. I work at the University of Melbourne as the APEX Australia Chair of Developmental Medicine, and I'm the Director of the department at the Royal Children's Hospital called Neurodevelopment and Disability. I also work as an honorary research fellow with the Murdoch Children's Research Institute. I've been working for quite a while now in autism. My background is in paediatrics and also in public health, and I'm interested in how common autism is, trends in autism over time, diagnostic clarity around autism, the outcomes of children with autism, and understanding the causes of autism, and our research focuses on all of those domains.
Thank you, Katrina. And next to Katrina is Charmaine, Bernie. Sorry, Charmaine. Had a mental blank there. Charmaine, could you please tell us a little bit about your professional background and the work you're involved in as well?
My name's Charmaine Burney. I am an occupational therapist and have been working with individuals with neurodevelopmental difficulties, including autism spectrum disorder, for over 15 years, both here in Australia and in the United Kingdom. I am currently the Autism Service Coordinator for below school aged children here at the Royal Children's Hospital, and completing my PhD exploring the early pathway to diagnosis for families. So we know this can be a really challenging and stressful time for parents in particular as they try and navigate through the services that they need. So it's a pleasure to be here today on the panel.
Thanks, Charmaine. And next to Charmaine is Dr. Alex Ewer. Hi, Alex.
Hi, Peter.
Who's losing her voice.
I've got a bit of a croaky voice today.
If you could do the same, please. If you could tell the audience a little bit about your professional background and the work you're involved in.
Sure. So I'm a clinical psychologist. I did my PhD with you, Peter, finished almost 6 years ago now. And my PhD explored neurodevelopmental difficulties like autism spectrum disorder and ADHD in children who were born very preterm. Since that time, I've been working clinically as a senior psychologist with the specialist autism team here at the Children's Hospital. And I'm working with Katrina and Charmaine in the autism research team. I'm the team leader of the team here at Department of Paediatrics at University of Melbourne, and an honorary fellow researcher at Murdoch Children's Research Institute.
Thank you. And we're very fortunate to have a parent perspective today. I think when we talk about disorders like autism, it's really important for us to get a parent's perspective, as it sometimes does differ from the perspective of health professionals. So today we've got Yaz Rosenblum from Melbourne, and Yaz has 2 children, both born preterm, and her oldest child, her daughter Ollie, has recently been diagnosed with autism, as I understand.
Yep.
And so maybe if you could start by telling us a little bit about Ollie's birth and her time in the neonatal intensive care unit.
Yeah, sure. So Ollie the pregnancy with her was normal. And at 36 weeks exactly, I had spontaneous rupture of the membrane, so my waters just broke. We don't know why. And when she was born, she was just over 2 kilos at 36 weeks, and then she was in special care while I was in hospital, and then 5 days after I was discharged, and it was really just for feeding and weight gain.
Mm-hmm.
But there were no known issues at that stage.
Right. So her neonatal course was very normal.
Yeah.
Yep. So tell us about her development, especially in the early years, the first maybe 3 to 4 years.
Ollie presented like a normal toddler, typical terrible 2, typical 3-nager. There were some, I would say, traits that she displayed early on, but nothing that you would attribute to her having autism. You would attribute it to her developmental stage, maturity, etc. So there was nothing really obvious. One thing that may have been obvious looking back was that she was a late walker. She walked at 25 months. And people used to often comment that she used to just sit and just observe the world, and she would just watch, which I find really interesting now in retrospect. Otherwise, she was a little bit shy, a little bit anxious. I was always that mum that was at the parties, not able to leave.
Mm-hmm.
But other than that, there were no obvious impairments or neurological issues.
So you obviously became concerned about Ollie,
Mm-hmm.
and so what was the process, and how did that eventuate?
So 2 years ago, Ollie's anxiety started to peak, and she started talking to me about some social issues that she was having at school, and we tried to navigate them together. Then the anxiety again just peaking, and she developed insomnia, so she wasn't able to sleep at night with all her worries. The beginning of last year, we took her to a psychologist just to have some input into what was happening with her. She was diagnosed with generalised anxiety disorder, and we were given some strategies on how to help her with that. We did a few of the strategies, but my gut was just telling me that there was something more going on with her, because she didn't quite grasp the concepts. They seem too abstract, and they're very literal, and she just didn't seem to understand. And so what a mama bear does is they dig and dig and dig until they work out what's going on. And I started researching online and found the presentation of autism and other, obviously, comorbidities in girls. I researched them online, and I could see that Ollie ticked the boxes for ADHD as well as autism. And so the next process was finding a psychologist that knew the presentation in girls that could support us and help us with diagnosis and assessments. And we had her assessed last September, and we had her finally diagnosed last year, end of last year.
Okay. Well, thank you and welcome.
Thank you.
We're really looking forward to your input during our question time.
Thank you.
All right, so now I'm going to pass over to Katrina and Charmaine, who's going to give us a brief presentation on autism.
Charmaine's leading.
Thank you so much. It's a pleasure just to introduce some background around autism spectrum disorder for those that might be less familiar with this diagnosis. And really we wanted to phrase this around autism having many faces. And again, by autism, we're talking about autism spectrum disorders, and it is true to say it's a wide range of presentations, and any individual with autism has their own unique presentation. So in terms of what we think about in relation to autism, we really want to just clarify that autism exists in all different areas, in all populations, across different age ranges, and across different cultures and countries. And really this is something that affects each individual in a different way, as we talked about. The AMAZE organisation, or which is an autism support organisation here in Victoria, has a really lovely definition which I think can make it clear in terms of the actual presentation ranges that we're looking at. And they describe autism as a neurodevelopmental condition which affects an individual's development and social communication. We're really concerned around two domains of development, and that is social communication and restricted and repetitive behaviours, which can affect individuals, again, with different levels of severity. And I guess autism, it's important to mention that it's a behavioural condition, and it's defined by a set of behaviours that actually can exist across the population with and without diagnosis. So it's not really until these behaviours are grouped together and us beginning to affect function that we might start to consider that a diagnosis that requires further review. And whilst on this picture that line is very clearly defined, in practice where autism begins and where behaviours that we might see in everyday social interactions and in the everyday population, that's much harder to define. And because of that, that's sometimes the challenges that people encounter when engaging in diagnostic services and attempting to understand their child or understand their own behaviours, if it may be in that adult space. So we like to think of autism as a range of dimensions or areas of concern, and again we can be in different places along these spectrums or of each of these dimensions. So it may be in the domain of communication that we might encounter individuals who are non-verbal, who have other means to get their messages across. At the same time, an individual with autism spectrum disorder may also be quite verbose, talk frequently, and not necessarily recognise those signs or cues that it might be time to take turns in that conversation. The same variation can be seen in social interaction. It may be that an individual with autism spectrum disorder can be aloof or avoidant of interaction, whilst others might frequently interact with others, but the way they do so is slightly unusual. It might be that they have significant repetitive behaviours that interfere with function, or it might be an individual where routine and repetition doesn't affect them as much. There can be specific interests in a particular area, or there can be sensory processing difficulties where we react to those everyday situations by avoiding those situations or being particularly sensitive to the world around us. Individuals with autism might also vary in their thinking skills. They might vary with their attention, being over-focused on some tasks, or have difficulties attending to any task for any length of time. And anxiety and mood issues can be very prevalent with individuals with autism spectrum disorder, and again affect them in different ways. So in terms of what then can happen following a diagnosis of autism spectrum disorder or autism, we can actually see that a range of professionals in both the education sector and the health sector might be involved in providing care for your child. It may be the case that you'll have each and every professional involved, or it may be just one or two professionals at any time, or one or two support people in the education system that are helping you at that point. And so I'll hand to Alex, who'll talk a little bit more about how individuals who have been born premature might have increased risk of autism spectrum disorder, or how that might present with this group.
Thank you, Charmaine. Yeah, I want to sort of bring the conversation now to children who are born very preterm. These are a precious group of babies who are born in a window of development where their brain is developing really quite dramatically. So from the age of 28 to 38 weeks gestation, you can see these pictures of brains here. The growth of the brain is quite remarkable. The yellow pictures of brains are the pictures of brains on the side of a child's head, and then the grey pictures are pictures taken from the top. So we can see there that just how the growth is it's so remarkable over that 10-week period. So if there's a disruption in that period, like a spontaneous birth, for example, then it's fair to say that that disruption is going to have a bit of an impact on this brain. It might be that the brain takes a little bit longer to develop, or might have some structural changes which has ramifications later on. If we move on to the next slide. After a child is born, there are some common difficulties if a child is born early and very small that we can see. We've talked a bit about the brain already, and what we know is that the brains can develop a little bit slower, and that can the diversity, I guess, in that development can be quite different. So it can be a mild impairment, so it might look like attention deficits, for example, or it could be a more significant difficulties with learning. Children born preterm also are more likely to have difficulties with their language, so that's a delay or an impairment in their ability to express themselves, but also to be able to understand others. Along with their developmental delays, they also might have some fine motor difficulties, which means that their approach to tasks and toys might be a little bit different to other children. And they also have some delays in their what we call gross motor milestones. So that's they're sitting, they're walking and crawling in the other order, sitting, crawling, walking, which might be behind those who were born at term. So as a clinician in our clinics, when we see littlies, babies or toddlers who come to our clinic, it's a challenge for us to try and work out whether these delays and difficulties are due to are a delay, and in that respect, if they get some support, that they might catch up to their term-born peers, or whether there's a developmental difference, which means that there might be some ongoing difficulties that the child and family would need to work through. We know that social difficulties are more common in children who are born preterm in comparison to their term-born peers. But I just want to stop and think about that for a moment, because having social difficulties, as Charmaine's just explained, is not the same as having autism spectrum disorder. And when you think about the common difficulties in terms of their language impairment and their difficulties with attention, which are common in children who are born preterm, it makes sense to think that these difficulties might mean that a child might have difficulties understanding what might be going on and being able to keep track of the conversation. That doesn't mean, again, that a child has autism spectrum disorder. But what we found is that children who are born preterm are a little bit more likely to be diagnosed with autism. And this is the study that I was involved in with Peter about 7 years ago now, where we followed up children who were born very preterm. And what we found was that the prevalence of autism spectrum disorder in this group was around about 4.5%. And that compares with about 1 to 2% of the general population. So the difference is the risks are a little bit elevated, but not a huge amount. So I think that's important to keep in mind. I've got a little picture of the toys there just to remind myself that, and remind everybody to talk about the fact that autism is more than social communication difficulties. It's also about restricted and repetitive interests and behaviours, and the other dimensions that Charmaine's already spoken about. So I guess some of the key points that I wanted to discuss today was that just to highlight that developmental delays and difficulties are common for children born preterm. And autism is a little bit trickier to detect and to understand. That's not to say, though, that if your child is presenting with some developmental difficulties, that we can think about starting some interventions and support. We don't need a diagnosis necessarily in those early years to be able to support these children. So that's an important point to keep in mind. If you're unsure or uncertain about your child, then I would really strongly suggest that you discuss your concerns and your child with your primary care provider, so that's your maternal and child health nurse or the GP. If you're linked in with a paediatrician, they are obviously a very good place to start. You can ask your primary care provider to complete a developmental screening tool. So that includes the parent's evaluation of developmental status, or the PEDS, or the ages and stages questionnaire. And your general provider is probably aware, but just to remind them to use your child's corrected age rather than their chronological age when they're looking at your child's general developmental status. We would encourage you to use one of these general screening tools rather than an autism-specific tool, because the validity of those tools with the population of children born very preterm is still uncertain. There is a fantastic website that I could refer you to called the Raising Children's website that perhaps you've had a look at, yes. And it's got an amazing a wealth of information about autism spectrum disorder. And in particular, there's a little tab there called Therapies and Services, which is a nice place to start if you're thinking about which interventions and therapies might be helpful for your child. So checking out that website is a great place to start. That's about it.
Okay, thank you, everybody. That's a great background to the question and answer session we're going to have now. So those of you who are tuned in, please send us questions. Maybe to get started, we can follow on your discussion, Alex, about preterm children and diagnosing autism in children born preterm. Preterm children are often at risk of a range of delays, delayed language, delayed attention, motor skills, and so forth. How do we differentiate at an early age as to whether the child is simply delayed? And I know you touched on it, and from a child who does have autism,
sure.
Or is it an issue at all? Is it something we just wait and see what happens?
There are some red flags, I guess, that I would be looking for if a child presented to me with some of these delays. What we're looking at is a child's level of social curiosity and interest in other people. A child with a language delay or a language impairment on its own, and attention problems perhaps too, will still go to approach another person, to show them toys, to try and interact with them, regardless of what their language skills are like. There is a difference there between someone without autism and someone who does, because someone who has autism is much more in their own world and interested in perhaps the toy, and it might do something amazing, and they don't look to share it with that other person. So those sorts of social interests is what we might be looking for.
Anyone else want to comment on that?
Well, I think speaking to the other point that you raised, Peter, about how important is it, people in the autism world have talked for a long time about how crucial it is to get an early diagnosis and get into appropriate intervention. That puts a lot of pressures on families, worrying that they're missing out on something that's key and missing out on a window of early development. I think more recently there's been a clearer understanding about how it's important to get help if there is delay in or difference in development, but how it's really important to target that intervention towards the type of help that the child needs. And that can happen within an autism spectrum specific intervention program, but it can also happen within what is called in the field eclectic intervention programs. So as long as you've got early childhood workers who understand early development can work with the family and the child to understand their particular strengths and difficulties, and the priorities of the family in terms of what they would like to see change first as they're living with their child. Then those non-specified as autism-specific services can provide fantastic interventions for children and outcomes. The other thing that we're learning is how helpful the input is from early childhood workers, or even during the early school years, therapists that people might be seeing in the community to help what we might call diagnosticians to understand the child, because as Charmaine and Alex have said, it's really important to understand the different dimensions, how they interact, how they are in a variety of different settings, so the early childhood setting at home or in one-on-one situations, maybe in a clinic. And information from the people that are helping with the intervention is really helpful to the people that are trying to make a diagnosis. There's some conditions in DSM-5, like learning disorders, that actually require a period of intervention before a diagnosis is made. So if a child's having difficulty with reading or with maths, you would try an educational intervention, and only after 6 months and watching the course of that child in that time would you decide whether it really is a learning disorder or not. And a lot of people today are saying that that would be a very useful approach with autism as well. Identify what the strengths and difficulties are, think about what interventions have been tried, and then look at the response to those interventions and how the child changes over time. So while we don't really recommend watch and wait in the maybe the most extreme form of it, we also don't think that a diagnosis is the only way to get the right help for your child.
So picking up on that point, and I want to ask a question from Rebecca, who's asked, when is the right time to start diagnosing? And I'm sure you get asked that question lots. So we've heard from Ollie's experience where
it was affecting her functioning.
And she's just recently got diagnosed at the age of 9.5, 10.
9,
Does anyone want to challenge that question?
No, well, I think the right time to diagnose is when the diagnosis becomes helpful and necessary to the child and the family. And so if a dimensional approach that Alex and Charmaine described is helping you to get the support that you need for your child, and you can see positive gains and supports in whatever environments they're in, childcare, school, and the diagnostic label would not add value in that setting, then it's not adding value and it's not going to be necessary. But if it's a point at which it's really important to understand what's going on with the child, for the family, for all the other people that are living and working with the child, and for them to be able to get the opportunity to achieve as much as they can in their life, then that's the right time for a diagnosis to be made. And that can vary from the very early years right through into the teenage, and increasingly recently adults are being diagnosed.
So building on that, is it possible to make a diagnosis in the toddler years? Is that an accurate diagnosis, or does one need to wait until the child's a little bit older?
So it's a really tricky question to answer accurately, and there's I think it's fair to say differences of opinion within the autism field of experts, and probably amongst parents and carers as well, about that. But I think what is known is that the younger a diagnosis is made, and if it is made in a child that has other difficulties with intelligence, cognitive reasoning, learning difficulties, that it's less likely for the diagnosis to remain valid throughout their life, or to be very helpful to the family. So yes, the diagnosis can be made in the toddler years, but with the caveat that it's important to continue to follow up and to still keep this very dimensional frame of making sure that you're supporting the child in relation to their specific needs.
Thank you.
Peter, sorry, if I
Sure,
could just add on
please.
that as well.
Yeah.
I think that as what you're saying is extremely, extremely valid, but I think that the government puts pressure on families also. For example, with FACSIA funding, that you need to get a child diagnosed before the age of 6 and you have to use your funding before the age of 7. They put a lot of pressure on parents to get this diagnosis and to get the early intervention, which they might see as a cure, so that the child is able to function, go to school, etc. So I think that from a family's perspective, there's a lot of pressure with FACSIA funding up to the age of 7, and then now with the NDIS.
Okay, so I completely agree, but what most paediatricians would say about that is that they haven't really liked that style of funding. They would prefer for the funding not to be like that. And currently we're in a period of transformation, as you mentioned, towards the NDIS. The NDIS does still have diagnoses on their website, but access to the NDIS is not hinged on a diagnosis or not. Although how it's working in practice in every different geography and region around Australia is still in development. But entry to early intervention with the National Disability Insurance Scheme is based on a functional assessment, and a dimensional approach to a functional assessment should allow as rapid access as not. There are still the HACWA-linked Medicare funding items that come with a Medicare-based diagnosis of autism, and these are the kinds of funding and service access things that come in to assist children and families, but sometimes they create unintended consequences in terms of the sequence of events. So paediatricians and child psychiatrists can still make a Medicare diagnosis of autism, and that will release some Medicare-funded items to families, and that should be done, as I was saying before, at the time that it's right to make the diagnosis. But hopefully the family and child or young person have been able to access the services they need before that.
Thank you. Next question's from Susanna Morris, and maybe I'll direct this to Charmaine. Is lack of eye contact a sign?
So yes, lack of eye contact is certainly something that's looked at and considered to be one of the symptoms of autism spectrum disorder, but certainly never on its own would that be indicative that that diagnosis would definitely be made in conjunction with a clinician. So eye contact can occur for a range of different reasons, and there can be an absence of eye contact for a range of different reasons. And of course, across different cultures, the level of eye contact and how we give eye contact differs. So we can never take one observation or one symptom in isolation when we're considering any developmental presentation, and particularly for autism spectrum disorder. And it can be the case that, in fact, some children with autism spectrum disorder will make eye contact continually, but it's a difficulty with actually modulating or knowing when and how to use that eye contact that is actually the presenting issue. So unfortunately it is a little bit more complex than that. Certainly a lot of families do report that that's one of the first things that they did notice, but never in isolation would I be too worried about eye contact unless we were seeing that issue in combination with other social communication issues or repetitive behaviours that seem to be over and above what we'd expect for that child's developmental level.
Thanks, Charmaine. Next question's from Dave, and I'm going to direct this to you, Alex, because Dave's a nurse and he understands that he's read the literature and he knows that preterm babies that are outborn, so that's babies that are born outside of a tertiary maternity hospital, have higher rates of difficulties as they get older. He wants to know whether autism's more prevalent in those prems that are born outborn.
Right. That's a good question. Thanks, Dave. I think I think it's fair to say that if there are more complications post birth, and that and certainly if the child is born earlier, in that sort of earlier than 28 weeks, there's a higher chance that there will be more difficulties, and then also a higher chance of autism spectrum disorder. So it may be, for example, that if a child acquires a brain injury post-birth or within that neonatal period, that they're more likely to have an intellectual disability and autism spectrum disorder as well.
Yeah, it's a very good question. There seems to be literature coming out now which is suggesting that the rate of autism is increasing in the children born extremely preterm. And there is some suggestion that might be because the babies that are surviving now are more immature than the babies that survived in previous generations. But we don't know the answer to that, and that we need more research to really decide on that. The next question is from Susanna Morris again, and this one's a really interesting question, and interested in Yaz's comments about this because of Ollie's diagnosis, but is about the differences between boys and girls diagnosed with autism, and whether they're actually boys and girls show different symptoms. Anyone want to have a go at that one?
Oh, I'll go for it.
Yeah.
There is a difference between the male presentation and the female presentation of autism, which I've come to learn. A lot of the traditional diagnostics are arguably skewed towards the male presentation, so sometimes it's actually hard for a diagnostics assessment to actually work out what's going on with the child. For example, a lot of girls do give eye contact because it's socially acceptable and they've learnt the social rules. Females and young girls learn the social interactions, they mask it, they social chameleons, they copy, they act, they're performing all day just to fit in. And I think that the anxiety leading to social interactions is what gets them unstuck eventually. So it's quite common for girls to get picked up late, if at all. It depends on who your health professional is. If obviously you take your daughter, to a paediatrician, and they say, oh, well, but they're looking at me, I think she's fine. I don't think that's an accurate assessment of where that child's at, but she will eventually become unstuck. But the presentation is very different, and it takes for the right person to know how they present in order to get the right support for your child.
Can I make some additional comments?
Yes,
please. It's a really interesting area because it's an area where what the clinicians say and what the research says is very different. Right. So a clinician's impression, and I would agree, is that girls present very differently, and in particular they've got more internalising symptoms, which means that they're not so obvious, I guess, in a classroom, compared to boys who might have more of those externalising behaviours. But interestingly, what the research suggests is that there's not a lot of difference between boys and girls in terms of their symptoms. And trying to unpack why there's a difference between the research and clinical impressions is really tricky. I don't know whether we as researchers are really are picking up on the very subtle differences between boys and girls, or the differences of the girls' presentation, or whether indeed we are over-diagnosing or under-diagnosing girls if they've got these subtle social communication difficulties, which as they go up through teenage years become more pronounced because hanging around with girls is really quite
socially sophisticated and they can't keep up.
Exactly.
Yeah.
So it's a really interesting area, and I don't know that we know enough now to say.
Yeah. I think one thing we do know is that the diagnosis of girls is increasing in Australia. I work with a colleague, Tamara May, and looked at Medicare diagnostic data. So most of the increase in autism in the population, not in preterm born children, is in the after school entry years, and there's a bigger increase in diagnosis of females in Australia in those years. And I was also interested in what you said earlier, Peter, about an increased diagnosis of autism with those born preterm, because we're seeing and have seen since I started my PhD in the late 1990s a big change in prevalence. And that's the same across the Australian population as a whole. So some studies are reporting now between 2 to 4% of children by the age of 11 in the general population are being diagnosed with autism, and we're still trying to understand really what that means. What's happened since the late 90s is the diagnostic formulations have changed. We've had DSM-4 change to DSM-5, and we've had a really big increase in the awareness of autism. We've had increased concern from parents about social communication difficulties and wanting to help early to prevent down, later in life problems that could occur. And so people are seeking help differently. I don't think there's any evidence that there's actually an increase in the types of problems seen in autism rather than a change in the way it's being diagnosed.
Mm-hmm. Thank you. And what about the prevalence rates between boys and girls? What's the difference there? And I'm getting the feeling that girls may be diagnosed at an older age.
Yeah, so I think that girls are diagnosed at an older age, and I think that tells us two things. It possibly speaks to the potential for camouflage that was mentioned, but also an indication of the severity of the problems that they're experiencing, and that's not to diminish them in any way. The children that we are seeing very early have really quite marked differences in the way they communicate, in the way they interact with other people, in the way that they play with toys, and those really marked differences are picked up early on. And when the differences are important and different but somewhat more subtle, then diagnosis comes later. But boys are also being diagnosed increasingly later. It's not just for girls, but the proportion, the relative proportion of girls and boys diagnosed is later in life is changing. But I'm not sure if others got things to add.
Would you want to make a comment?
Really just only from the perspective of, again, some girls and females that I know. A lot of the mothers of daughters that have been diagnosed, often it's quite a confronting process, and they actually also go and seek a diagnosis at an older age because they've realised that the apple and the tree, very close. Yeah.
Got a question from Kaz, who wants to know, is not being interested in playing with other children and growling at them an indicator?
Well, once again, I think those kinds of symptoms can require further investigation, but again can be occurring for a range of reasons. So play and the complexity of social interaction, even at a very young age, it can vary because of an individual's language level, the way they're processing information, their play preferences, their mood on the day, and that can have a significant effect on the way they're interacting with others. I think if you're seeing those behaviours in a really pervasive way, which means it's happening most of the time and across settings, so it's at home and in the local playground and at daycare or at school, then that might be something that just requires further investigation. But once again, we'd want to be looking at the range of different developmental areas and looking at that individual's communication skills, what language they do have, how they're using those skills in their social environments, what their play preferences are with other children or indeed on their own, and looking at all of those features, including attention to task and cognitive or thinking skills, their ability in that area, and we can start to put things together, and in that way we might be able to determine whether this is that observation is part of a bigger picture, or it's just occurring again in isolation and just might require some individualised support or strategies.
Okay, I've got a rather long question. It's a bit of a paragraph actually, so I'll read it out to you. Hi, just wishing to send I'm a mother of a 3-year-old preterm child, I think. My daughter, almost 5, has displayed signs of autism since age 1. Her behaviour has become increasingly difficult to manage with violent outbursts, defiance and explosive episodes. The creche where she attends has reported issues with defiance to a lesser degree when compared with home. However, the creche, family and friends all agree we need help and assessment, etc. After a referral to a paediatrician and waiting several months for the appointment, while the behaviour deteriorated further, the paediatrician asked our daughter a few questions, asked her to explain a few pictures and identify emotions. The paediatrician then assured us she seems fine and no further action was required. We find it hard to accept there's nothing wrong, and I know it's not normal behaviour. Is there somewhere we can get help we need? Have we gone through the wrong channels?
Thanks for that question. I think it's a very common presentation, the kind of story we will hear from mums and dads as they come and see us with children, and often with information from the kinder that they're attending or the childcare with concerns. But what I heard, and I hope that was what was intended, is that the behaviours are the main problem here, and thinking now about the dimensional approach that Alex and Charmaine talked about, we would say the behaviours do need attention, but it might not be the right point in time for diagnostic formulation. And if we can get the right sort of help for the behaviours, that will certainly help to find out what happens next. Are the behaviours able to be changed or not? Could there be something underpinning the behaviours that hasn't been identified? Difficulties in understanding what's going on, for example. So generally in that situation, we recommend mums and dads see their GP, who can access a support plan for the little one, usually involving talented clinical psychologists like Alex and her colleagues, and will work with mum and dad to understand what's coming before the behaviour, what might be triggering it, what the behaviour itself is like, and come up with strategies and approaches for what could be done to change it. And then perhaps in keeping with what we heard, if those things are effective, that will be great. The creche, and I'm sure mums and dads will be happy. If not, and there are barriers to success with those more typical approaches, then the psychologist will be able to talk with the paediatrician and raise concerns from their perspective, having trialled what could be effective interventions.
Mm-hmm. Yes, do you want to talk about your experience with getting an assessment done, whether you found any barriers or you found it quite an easy process to...
I didn't find any barriers. Thankfully, I had a close friend of mine who had an autistic daughter with autism, and she was actually able to guide me onto who the best paediatrician was to perhaps see, or where I could get assessments, because I knew that it was really important to get someone that understood how the girls present, because I didn't want to have spent the money for assessments and gone through the time, not had any assessment or any diagnosis. The diagnosis is fine, but we needed help and we needed support because the behaviour was becoming quite severe at home, not at school, just at home. And so it was imperative to keep on it and to make sure. So I didn't have any barriers, thankfully. There are other barriers, but for the actual assessment and the diagnosis, it was pretty easy, thankfully.
Telly asked a question about prevalence. We're going back to that, and I think I think you can answer this question pretty quickly because you touched on it. Why does the prevalence of ASD or autism, why has it increased? Is it due to increased awareness or other? I can't see the rest of the message, but I think you were touching on that before.
Yeah, and I think Look, there's been a lot in the media about an epidemic of autism and people being worried about that. What's come with that is a whole lot of theories about the cause of the epidemic, and some of them have been incredibly unhelpful for children and families. The immunisation causes autism concerns, for example, but there have been others about living in the modern world, and we don't want to dismiss them out of hand. Obviously, it's important for theories to be generated, for research to be done to prove or disprove them, as has been able to be done with the immunisation theory. But if there is something or a theory, a cause that's driving an increase in autism, it's a very small part of what's going on with the increase in autism that we're seeing today. And generally experts agree that it's around the change in the diagnosis, particularly from DSM-4 to DSM-5, and then ICD-11 is following that path. A change in awareness, a change in the approach of the community to understand and be interested in autism, and the autism advocacy agencies have done a fantastic job there. And in Australia, we touched on before the HAQA funding, and the diagnosis was a pathway to services that were not available otherwise. We're not sure how much that's influenced the prevalence, but we think it probably has influenced paediatricians and others' willingness to diagnose, to get families the much needed services, and that we're hoping that the move to the transformation to the NDIS will diminish that need, so that really what we want as paediatricians and allied health professionals is for children and families to get to the services they need with a minimum of out-of-pocket costs, to really help them build for the life ahead.
So that we've talked quite a bit about diagnosis. Let's look at support. And Jane asks a question about getting support through schools. How do we do that? Charmaine?
Yeah, so I think it's a really great question, and there's lots of different ways that information can be shared and is currently shared between health professionals, education providers and parents. Parents often find they're needing to be in that role of championing that information and making sure those communication channels are open. So unfortunately, there are some barriers. These departments can sometimes sit separately, making communication a little bit more challenging than it would be if we were all under one umbrella. Despite that, there are really good models and really good examples we hear all the time around health professionals and education staff getting together, having meetings, sharing information via emails. I'm not sure if that's been your experience.
A little.
Yeah, so I think it's about really making sure that any information from the diagnostic pathway or any strategies that clinicians are using with that individual and the parents are finding particularly helpful, the individuals are finding helpful, that gets shared with the education providers in any way that's helpful. Sometimes it's best just to go directly to your teacher and have those conversations and share that information. Sometimes more formal processes, or having inclusion support staff in the school, or the principal or assistant principal or the year level manager involved, can be helpful as well. Again, the more people that are aware of what needs to be done to support that individual in the best possible way, the better the outcomes can be for that student. So there's no easy formula to say, other than just keeping the communication channels open, unless anyone else has.
Yeah, I guess I would encourage families to arrange regular meetings with their teachers, and if they can include clinicians who are involved in supporting that family and child as well, then all the better, and have an individualised learning plan with some goals that they regularly update and keep that communication flowing.
There is with the Department of Education, however, is that you're not eligible for an individual learning plan or an SSG if your child's not funded. And that's a bit of a roadblock that some families might experience. So from the parents' perspective, but I think that I agree. Just open communication with your teachers and school is key to get the right support. Absolutely.
I think it is important to mention that in Victoria, in this education system, there are some rules about funding, how it's allocated, what the diagnostic process needed to include, what a report might need to include. That's really important to understand along that pathway. That can differ in other states, and depending on which sort of school system you're in, public or independent schools might operate slightly differently. So again, I don't think there's a broad rule here to follow, but just to say, I think you've highlighted an issue which a lot of families come across, which is trying to understand those rules, make sense of what's required, and that can be a bit of a process that just takes time and support from health professionals and education staff to understand.
It definitely seems to me that schools are much more educated and aware of autism now than what they were.
I'd agree.
So we're quickly running out of time, but there are a few more questions I'd like to get through. There's one from Leanne who asks, and I'll ask this to you, Alex, because it's related to preterm birth. Are there any interventions that can be implemented in the early weeks and months of for preterm babies?
Yeah, there's, and I'm sure that you could answer this question perhaps better than I can, Peter, because it's been a while since I was involved in the Premi research world. But there's certainly there is an understanding about the importance of skin-to-skin contact in those early weeks and months. And I know there's some evidence to suggest things like kangaroo care, if and when it's possible and available to families to be able to use. And I know that that's a big if, because there's other complications and other issues to consider. But the amount of time that you're able to spend with your child or infant, the better. And also using language with infants while they're in the NICU is a nice way of exposing them to ways of hearing language, so that they have the maximum exposure and opportunities to learn.
Yep, thank you. So early intervention is helpful for children born preterm, but there's no evidence to suggest that early intervention for preterm children reduces the incidence of autism, unfortunately. But we really haven't looked at that. We don't have the numbers to really know that for sure. An important question I think we need to ask is, what about those children who have signs of autism but don't have a diagnosis? What should we do for those children? Should they receive services? Should we do nothing? What should we do for those children who just don't reach the threshold for a diagnosis?
Well, I think following the dimensional approach that we were talking about before is that, in an ideal world, services are available based on the strengths and difficulties of every individual, whether that's in the childcare setting or at school later on and in the workplace. So I think if there are difficulties and if they are creating a functional problem, an inability to progress and to achieve what is optimal, then it's great to be able to put services around. I think the tricky point here comes, and referring back to the slide that Charmaine used with the line around what is autism or not, is understanding that there are very many different ways of being in the world. There are some people who like more structure in their lives than others. There are some people who like being out in a crowd more than others. And there are some people that are going to seek out to have huge social circles of friends, and others will be very content with immediate family and one or two close friends. So these are really important differences of ways of being in the world. As a psychiatrist that I used to work with said, a problem is a problem if it's a problem. So if it's if the way you are in the world is creating difficulties, that's in an ideal world where we would like support to follow.
Yeah. And very, very briefly, I think we should touch on parents and families. The parents and families need to look after themselves. What can they do? Maybe Yaz?
Find your village or villages. The process or everything involved with having a child with any neurological disorder can be a very lonely place, and I think that parents supporting parents is crucial for the mental health of parents. My husband and I actually saw Ollie's psychiatrist at a time to get support on how to manage her behaviour, so support from health professionals as well. And I guess just getting rid of the stigma and the shame from parents' perspective, and that shame of no one needing to know their child's label, is just to strip it away, because at the end of the day someone else is going to label your child, and what you're doing with the diagnosis is giving them the correct label and the access to the right support. And so I think that the best thing that as parents we can do is to support our children first, ourselves and the family as a whole, because it can be a very daunting time.
Thank you very much. Okay, we have run out of time, so I'd like to thank the audience for joining us today and sharing their stories with us and their questions. Of course, thanks to our wonderful panel of experts, Katrina, Charmaine, Alex and Yaz. I'd also like to thank our organisational partners, which includes Life Little Treasures Foundation, the Murdoch Children's Research Institute, the Royal Women's Hospital, the Royal Children's Hospital, Monash University and the University of Melbourne. We got through most of the questions, but there were a few questions were long and I couldn't open them up and ask them fully, so we'll get back to you on those questions. So I apologise that we weren't able to address all the questions today, but we'll get back to you hopefully in the next half hour or hour. We'll also be putting a short poll out. We'll be very interested in getting your thoughts about how today's session went, and we're also very keen to hear about what other topics you would like us to cover in the future. We have a session planned in the near future on ADHD, or attention deficit hyperactivity disorder in children born preterm. So on that, I'd like to thank everybody again and wish you goodbye.